Congratulations, Nursing 111 students. You made it into the program. I know how hard it is to get in this program, and you should be proud of yourself. Now the work begins. The most important part of nursing is the nursing process, and we will go through each step of the nursing process, and you will be using this every week in clinical and hopefully throughout your careers. What is the nursing process? Basically, this is in your book on page 5 in Lewis. It's a problem-solving approach. It's a process that we look at judgment, knowledge, and actions, and we want the best outcome for the patient. That's the bottom line. Once started, it's continuous and cyclic. Nursing process never ends. What does this mean? It's a step-by-step framework for clinical decision making. It helps you to guide quality care. We're all about quality. It's very organized and it's goal-oriented for problem solving. It's evidence-based, and you will have a whole lecture if you don't know what evidence-based is, and it focuses on patient outcomes. It is a critical thinking process, so the nurse can give the best possible care. And it has become the standard of care for the nursing profession all over the world at this point. So we all speak the same language. So what is critical thinking? According to Paul Enos and Norris, the disciplined intellectual process of applying skillful reasoning is a guide to belief or action. Basically, it's purposeful and reflective. It's a mental activity using your reasoning and your analysis and decision making relevant to the discipline of nursing. So when we talk about critical thinking, we're talking about it in relative to the discipline of nursing. Critical thinking in the nursing process is the ability to think in a systematic and logical manner. You have to keep an open mind to question and reflect on the reasoning process. It's used to ensure safety in nursing practice and, most importantly, quality of care. Critical thinking asks you to think about who, what, where, why, define, clarify, using all those questions to critically think about a problem. How do we do this? The nursing process is a systematic and logical approach to the delivery of nursing services. That's MCC's Department of Nursing's definition. It's 5 steps, and they have an acronym, which we call ADPI. A good way to remember it is the nursing process is a delicious pie, So this ADPI process allows nurses to identify real or potential problems, develop solutions, and monitor the results of the solution. So the first phase is assessment. It's a deliberate and systematic collection of information about a patient to determine his current and past health status, his functional status, or ADLs, and what he or she can do, and the present and past coping patterns of that patient. Most essentially, it has got to be accurate and complete to make sure that we get the right diagnosis for the nursing process. So in assessment, you collect data, you organize it, you validate it, and you record it. So there are 2 basic ways of collecting data: subjective and objective. What is subjective versus objective? Subjective, sometimes they're called symptoms. You can't measure it. It's data that's not measurable. You can't see it. It is usually reported by the patient, and you usually get subjective data by interviewing the patient. Examples are, I feel nauseous, I'm in pain, I'm tired. You can't see tiredness or nauseousness. It's coming from the patient's mouth. It's subjective data. Objective data, or in other words, signs, they all have to be measurable. These are things that can be seen, heard, and felt, and it's usually obtained by observation, doing a physical exam, and looking at the outcomes of tests. Examples of objective data are vital signs, body language, watching their body language, lab results, and hearing crackles in their lungs. It's a specific sound in their lung that gives you some information. So how do we get all this information? We perform a health history. We have a conference that will be going through health history extensively. So what it is you're gathering all the information about the patient, health status, both current and past, because past health status can matter. But you use a systematic process because you don't want to exclude any significant data. It can be subjective or objective, and it can come from a primary source or a secondary source. So what is a primary source? It's the patient, basically. And there are several different secondary sources. It could be family or caregivers. Medical records are considered secondary sources. It includes information from various health professionals, includes their labs, their past medical history is usually in their medical records. Other healthcare professionals sharing information to you when they're transferred to the unit or even given report. And then professional literature. You can use professional literature as a source for your data collection. There are three methods for collecting data. Observation, which is basically just using your senses. Your vision, your smell, listening, touch. You go in, you look at the patient, you see what's going on, and sometimes it's very obvious there's something wrong. The patient's blue, they're obviously not getting enough oxygen. So observation, very simple one. The next one would be the interview, and it's a purposeful conversation. There are three stages for an interview. The opening and introduction, which actually is one of the most important ones. You want your client or patient to feel comfortable with you. You want to establish a rapport. When you go into a room, you should address them by Mr. or Miss Smith and ask them, what would you like to be called? And then use that word. Some of the older people like to be addressed as Mr. Other people like to be addressed as, hey, just call me Grant. And get a rapport, be happy, and explain what you're going to do. Just don't start barraging them with questions. Say, in order to figure out the best care possible, I'm going to ask you a bunch of questions, and I'd appreciate you answering them so we can help you. So the second part is the body, which is the main meat of it, is how the patient responds to communication, the interaction between the two of you. There are certain communication techniques that nurses should use, and we will be teaching you those techniques. And most importantly, it's important to make the patient feel comfortable. If the patient does not feel comfortable, you're not going to get any information out of it. And then there's closing. Usually the nurse closes an interview. Sometimes the patient wants to keep talking and talking and talking, but usually you have other things to do too. But keep the window open for further discussion for any needs from the nurse or the patient. The third is the physical assessment examination. And this is a systematic method of way of examining the patient. And we call it head to toe, and we'll teach you throughout the semester how to do a correct physical assessment. It's very important. You'll be doing them on your clients in the nursing home every day, and you'll especially be doing them in the hospital. There are four basic things that you use for a physical assessment. They're inspection, auscultation, palpation, and percussion. Inspection. This is your visual exam. Make sure the patient removes other clothes to observe the skin in different areas. Of course, keeping their privacy. You just don't come in and say strip naked, but as you're doing things, washing up the patient, you're going to be visualizing and inspecting to see everything's okay. Especially in the buttocks in the nursing home patients, because that's where they tend to get pressure ulcers, and you'll learn all about pressure ulcers next week. One of the big things is to make sure you have enough light, of course. You're looking for things, the color, texture of the body. Is there any moisture there that could help break down the skin? You're looking at the shape, size, color, symmetry of the body. It's just your visual examination. Palpation is another method that we use. Palpation is basically touching, pushing. We use the pads of our fingers because they're more sensitive. We can feel things easier. It's used to determine a bunch of things, texture of the skin, the temperature, is there any vibrations anywhere in the body? You can tell the size and mobility of the organs, or you can feel if they have a mass in there. Distension, which is the bloating of the stomach, and we'll be talking more about dissension. It could be a bloating of the stomach, it can be a bloating of the bladder, but you'll feel this bubble when you push down with palpation. Taking a pulse is palpation. You can feel the pulse. And of course, pain. If you touch somebody on their shoulder and they scream out, then obviously they're in pain, and that's part of your physical assessment. Then there's percussion. Percussion is probably the hardest skill to learn. It's striking or tapping to produce a sound that can be heard or vibrations that can be felt. It's usually used to determine size and shapes of organs. You use it on your lung sounds, use it on the belly. It's the hardest one to learn, but we will be teaching what it is, and we don't expect you to become experts at it at this point in time. It's even I have trouble sometimes percussing things that make sense to me. And last but not least is auscultation. And that's listening with your stethoscope to different sounds that are produced within the body. And certain sounds tell you certain things. The diaphragm of the stethoscope, which is the bigger part, best transmits high-pitched sounds, and the bell is for low-pitched sounds. The majority of this class we will be using the diaphragm for auscultation, and we'll be teaching you how to do that. So after you've collected all the data that you need through the methods described before, you need to put it in a written format and an electronic format. Most of the hospitals and some nursing homes has what's called an EHR, or electronic health record, or EMR, electronic medical record. All the hospitals have them. St. Anne's, where I'm going to be at, has it, so it'll be an electronic format. You refer to it as a nursing health history or a nursing assessment, and what you're trying to do is identify patterns. Some agencies have specific frameworks or models. Our framework is going to be ADPI. And it all comes down to basic needs. Think about Maslow's hierarchy of needs. So you organize the data in that manner. Next, you have to validate the data. Double check it. Does it make sense? Is it complete? Does that, temperature of 104 make sense to you when the patient is not warm at all? And so you have to sometimes go back and validate the data. Once you validated it and you're all happy that it's correct, you'll document it. You record it, patient data, factual and concise. When you write notes, it's got to be very concise. We will teach you how to do that. Don't throw your own opinions in the events. And when documenting the patient's own words, you put quotes around it for the subjective data. When he says, like, I'm in pain, you would put quotes around that when you document it. So let's go to a scene. We have Mr. Klutz, a 27-year-old male who was admitted 1 day ago after falling off a ladder trying to clean his gutters. He sustained a right femur fracture, broke his leg. He's currently in traction, and his only other medical diagnosis is type 2 diabetes. So, we do a health history on Mr. Klutz, and we organized the data, and we pulled out a couple things that we want to look at. So, some of the subjective data, he reported a pain level of 8 out of 10 in his right leg, which is high. He's got no sleep, and he's a marathon runner, so since he has a broken leg, he's worried they'll have difficulty running in the future because of this fracture. Some of the objective data is his vitals: blood pressure 140/90, heart rate 110, respirations 18, and temperature 37 Celsius. He's in traction. We can see that. His face is grimacing, his hands are clenched, and then he was given 5 milligrams of oxy over 8 hours ago, and the order is written for every 6 hours PRN, which means as needed for pain which is greater than 4 out of 10. So that's the objective data. You can see we got it from observation, we got it from the chart, and we got it from looking at tests that are vital signs. So that is what assessment is. Now that we've collected the assessment data, we're ready to move to the next phase of the ADPI process, diagnosis. So now that we have learned what assessment is, we're moving to the next stage of the nursing process, diagnosis. Again, we have our ADPI, just a quick review to look at it. And what is the diagnosis portion of it? We're analyzing the data that we collected. We're trying to identify any health problems, risks, and strengths. And then out of that, we're going to formulate nursing diagnostic statements. And they have to be very specific, and we will show you how to do that. So where does the nursing diagnosis come from? Your ACLY book. NANDA, or the North American Nursing Diagnosis Association, creates these nursing diagnoses. They're universal, and they change them every 4 to 5 years, adjust them accordingly. Their definition is, it's a clinical judgment about the individual, family, or community responses to actual or potential health problems or life processes. The nursing diagnosis provides the basis for the selection of nursing interventions to achieve outcomes for which the RN is accountable for. So, the nursing diagnosis is standardized language for communicating clinical judgment, so everybody understands it. And you'll find your nursing diagnosis in your ACLY and LAGWIC textbook called the Nursing Diagnosis Handbook. Hopefully you have it here today with you. So nursing diagnosis is not a medical diagnosis. Medical diagnosis is something like high blood pressure, asthma, COPD. Those are medical diagnoses. Only providers can determine a medical diagnosis. And the medical diagnosis is the act of identifying a disease from its signs and symptoms. So they're taking disease from signs and symptoms, and they're looking at the etiology. Maybe what's the cause of what's the problem is, or there may be a set of causes, or a manner of causation of a disease or condition. But that's how you form a medical diagnosis. You cannot form medical diagnosis. So what is a nursing diagnosis? It's a statement of a health problem or a potential problem in the client's health status that a nurse is licensed and competent to treat. There's also another problem, and it's called collaborative problem. And that's when everybody gets together, the nurses, other health team members, to treat a particular problem. The physicians focus on complications with the medical diagnosis. The nurse focuses on the impact that the diagnosis may have on the patient and the patient's response. So see the difference there. But we all talk about it together, and that's called a collaborative problem. Nursing diagnosis depends on the assessment phase. Like we said, the quality of the data acquired during the assessments going to give you the accuracy of the nursing diagnosis, and how well you use clinical reasoning to organize and analyze that data determines the appropriate nursing diagnosis. So the assessment data used to determine the nursing diagnosis, if you open up your Ackley book and look at any of the diagnosis, you'll see something called defining characteristics. These are the signs and symptoms gathered at the time of the assessment. Substantiating data, so this is what you actually observe in your patient that supports the defining characteristics. And then risk factors are any attributes, characteristics, or exposure of an individual that increases the likelihood of developing a disease or injury. Something like the side rails aren't up on the bed, they're at risk for a fall because of that. There are 3 types of nursing diagnosis. Actual, the patient actually has a problem at the time of the assessment. Risk for, potential, again, the problem does not currently exist, but there are risk factors that indicate a problem is likely to develop unless an RN does some interventions to prevent that. Then there's health promotion. This goes beyond being sick. You're doing things to prevent yourself from being sick. And it relates to the client's preparedness to implement new behaviors to improve their health condition. An example of that is smoking. How do we determine a nursing diagnosis? You got your subjective and objective data. That's the assessment phase. You do your data analysis and interpretation. You cluster your data. And from that, you can identify problems, risks, and strengths. So how do you analyze and interpret? You compare your data, what you have collected, against what is expected. Is the data normal or is it abnormal? You look for gaps or inconsistency. Does the information you collected make sense to you, or do you have to go back and get some more information? So what type of problem does the abnormal data point to? So, and you have to identify if the data suggests a problem, a risk, or it's a wellness-focused issue. You cluster the data, you put all the clues together, you look at the patient's response and symptoms, you organize the data, then you look for common patterns. So you make inferences about the data to help formulate tentative nursing diagnosis. When you do this, you must include the patient. How does the clustered data support your proposed nursing diagnosis? Does it make sense? Is the problem a nursing or medical diagnosis or a collaborative problem? So for a quick review between the diagnosis and problem, nursing diagnosis is using clinical judgments about the patient's response to health problems or life process that nurses are licensed to treat. Medical diagnosis, as we said, they look at the problems with the structure or function of an organ or body system requiring diagnosis and treatment by a physician. A collaborative problem is both medical and nursing interventions that we put together, and it's to prevent and treat the problem. You would begin with the statement, potential complication. So how do you formulate a nursing diagnosis? They may have 2 or 3 parts. MCC uses the 2-part statement. Part number 1 is the actual nursing diagnosis found in Ackley that identifies a problem or potential problem. Part 2 is the etiology, which is related to the phrase following the nursing diagnosis. So you must use related to in your statement. It's the probable cause of the problem and must be within the domain of the nursing practice, and it cannot be a medical diagnosis. And part 3, which MCC doesn't use, they include the statement in the nursing diagnosis, or the symptoms in the nursing diagnosis statement, which is the defining characteristics, but we don't use that part. So what do? You look at the Ackley, you have your data, all collected. And all the nursing diagnoses are in your NANDA book, your Ackley book, and it's on the back and front cover of the first pages of the book. You read the definition in Ackley, and when you go to that nursing diagnosis, you compare the defining characteristic or risk factors to your patient to see if they match and see if this is an acceptable nursing diagnosis. There are some challenges in choosing a nursing diagnosis. One of the big ones is jumping to a conclusion without having enough clues, too little information. And another challenge that students struggle with in the beginning, they forget to do the etiologic or related to factors. Use Ackley in the beginning, they have them in there. You'll come up with your own as the semester goes on. Another challenge is inferring beyond the data, making in your head what it could be when the data doesn't support that. Don't infer it. Sometimes reading the data incorrectly is a challenge. And a lot of times missing clues when you're brand new because of lack of knowledge and their experience. It's hard to choose a nursing diagnosis. And not having patient data to support the chosen nursing diagnosis. You have to have the data to support the chosen nursing diagnosis. If you don't have that data, you're not looking at the right nursing diagnosis. So let's go back to our Mr. Klotz. Again, he was admitted, 27-year-old, after falling off the ladder. He's got a broken leg, he's in traction, and he has diabetes type 2. So we're going to try to choose a nursing diagnosis. So we analyze the data from the assessment portion to identify the nursing diagnosis. And our subjective data was he reported pain 8 out of 10, he got no sleep, and he's worried he'll have difficulty running because he has a broken leg. His objective data, the BP 140/90 and heart rate 110, that's both high. His face is grimacing, his hands are clenched, and he was given 5 milligrams of oxycodone, pain reliever, over 8 hours ago, and the order the doctor had written for is every 6 hours, PRN. Again, PRN means as needed. So now we're going to look at possible nursing diagnosis for Mr. Klotz. We open our Ackley book and we scroll down and we see risk for constipation and related to opioid use. At this point, you may or may not know that opioids cause constipation, but they do, so that could possibly be one of the nursing diagnoses. Risk for falls related to unsteady gait. He's in traction. Even when he gets out of traction, he's probably going to have to use crutches or a walker or something like that. So he's at risk for a fall. Impaired skin integrity. He's laying in bed all day, so he's not moving. The skin could break down and create a pressure ulcer. So that's another nursing diagnosis from your Ackley book that you could use. Acute pain related to femur injury. Notice I did not say femur fracture because that is a medical diagnosis. But he is saying he's at 8 out of 10 pain. He's grimacing. His hands are clenched. So it's obvious he's in pain. So acute pain would be a good nursing diagnosis. And then anxiety related to fear of not being able to run. He stated that he's worried that he won't be able to do his marathons because of this fracture. So every patient will have more than one nursing diagnosis. Once they've been identified, we need to find out which is the priority. Usually we use Maslow's hierarchy of needs. Physiological needs come first. Think of ABCs, airway, breathing, circulation. Those needs need to be taken care of first because the patient could die without that. And other things that are physiological are like pain, physical discomfort. If there's no physiological needs in your diagnosis, you move up the pyramid to the next level. The lowest priorities would be at the top that are non-life-threatening or very minor. So here's just a picture of Maslow's hierarchy of needs again, versus physiological, and safety, and a lot of times those go hand in hand. Those are the ones you would make highest priority. So, well, let's take two of the nursing diagnoses that we came up for Mr. Klutz. We have anxiety related to fear of not being able to run, and acute pain related to femur injury. So which is the priority? Obviously it's pain. Why? Because it's physiological down at the bottom. We'll have to deal with his fear of not being able to run later after we solve his physiological problems. So that's how finding nursing diagnosis work. So I would go into your ACLE. These are going to be common nursing diagnosis that we're going to use this year while we're in clinical. Remember, each day in clinical, you will have to come up with a nursing diagnosis. And you won't keep repeating the same ones every week, because everybody in the nursing home pretty much is at risk for falling or at risk for skin integrity. Not everyone, but lots of people. So take a look at your ACLE, get used to it, just kind of look at defining characteristics and the related to issues, and get a feel for what we're going to be asking you to do each week. So remember, the nursing diagnosis facilitates individual care. It promotes professional accountability and autonomy, and it's a good way to communicate between nurses and other healthcare team members. So once you pick the diagnosis, that's going to affect the planning, implementation, and evaluation steps of ADPI, which will be the next lecture. We will be teaching you how to come up with realistic goals, how to figure out interventions to reach those goals, and how to evaluate whether those goals are met.